Welcome to the Thought Leader series brought to you by Rare Cancers Australia. In season 1 of this series, we're piloting candid conversations with some of the brightest minds in the Australian cancer community. People with a strong vision for what things could and should look like now and into the future. In this series, you can expect real questions with real answers and fresh perspectives on what needs to change and be done to make things better for patients.
You don't get a second chance at life, nobody does. And if you've got a serious life-threatening illness, then I think you're entitled to receive the best. And I think our society expects that, and I don't think they always get it.
In this episode, RCA Chief Executive Richard Vines speaks to Professor John Zalcberg, Head of the Cancer Research at Monash University. John was Director of Cancer Medicine at the Peter MacCallum Cancer Centre for 17 years, as well as their Chief Medical Officer for 6. He is highly regarded both nationally and internationally as a leader in his field, is a mentor to some of the most accomplished clinicians in Australia, and a well-known advocate for patient access to new cancer drugs.
So, welcome, John.
Thank you.
It's great to have you here, and we've done some research on you, but particularly your early life is a bit of a mystery to us, and so I have a vision of you as being a serious student at university and high school. But because of the saxophone and your love of the saxophone, I also have this slight image of you sneaking off into jazz clubs and playing in smoky venues. And I thought, can you either debunk or confirm that image of your early life?
Well, I can guarantee that I didn't sneak off into smoky venues and play the saxophone. I took up the saxophone when I was age 50. And I'd always really felt that the music from the great sax players of the past was just so wonderful and so inspiring. And I'd never played a musical instrument, really. I'd failed violin classes at the age of 4, as European parents will want to sort of test their children early on. So I'd always wanted to play, and for my 50th birthday present, I gave myself saxophone lessons. I had to pass an exam for the teacher to take me on, an aptitude exam.
Right.
I'm not quite sure what the criteria were, but he did agree to take me on, and I remain a student ever since, and a great love of the jazz and the saxophone.
Yeah, fantastic, and it must take you away from the tasks day to day of dealing with cancer patients and all that you do.
When you're trying to play the high E, you can't think about anything else.
Fair enough. Fair enough. And like, I think 95% of your oncologist colleagues, you also bike ride. And I asked a question the other day. I said, "Is it compulsory for oncologists to ride a bike?"
Yeah, look, I've been bike riding for a long time as well, and it was interesting. I used to do. I think a lot of middle-aged men started bike riding when they couldn't play squash anymore or play tennis because of all the injuries they were getting. So anyway, I just started bike riding, and I've enjoyed it, and I continue to bike ride.
Yeah, and you have quite a sporting pedigree in your family too, and your son is an Olympian. In table tennis, and I did ask you this question about whether you were the inspiration, but and your answer was the last time you beat him was when he was 11 or something.
Correct. No, I wasn't the inspiration. He saw an exhibition game when he was really young, about 10 or 11 years of age, and came home and wrote a note to us and said, "This is the person I want to coach me play table tennis." And we were a bit surprised because we didn't have a table tennis table at home or anything like that. But anyway, as they say, the rest is history. He went on to compete at 2 Olympics and the World Games, but now doesn't play at all. It's after 2 little girls.
They can be a preoccupation, including for grandparents.
So.
Yes,
I think so.
Yeah. So we go back to the late 80s when you were the clinician looking after my wife Kerry, who subsequently passed in 1990 from breast cancer. And when I met you again as part of the Cancer Drugs Alliance, which is something we'll come to later, And I reminded you, you said, yes, I remember, you never forget the young ones. And it made me, at the time, I thought that's a consequence of your choice of career, and I was interested in understanding why you chose medicine, and then increasingly why you chose cancer, why you chose as an area of study.
Yeah. Well, look, Richard, when I was growing up, I'm the eldest son of Holocaust survivors, and who never had a chance for an education, essentially, and so survived the camps during the war. So when I was born in Australia, we used to drive past hospitals, and my mother would point out the hospital and say that I was going to be a doctor, and I never actually contemplated anything different. And so when I graduated from high school, I only had one course down, which was medicine, and if I hadn't got into medicine, I'm not sure what I'd be doing now, probably something quite different. But anyway, so medicine was always the thing I was going to do, and it was to give to the community what the community had given to my parents in really saving them and giving them refuge here in Australia. Oncology was a bit different, I think. It was more, that was more serendipitous. I think I was interested in all of medicine. I was intrigued by the intellectualism, by the science. But in the end, I think what oncology gave me was the fact that you could give and be rewarded by the way that you were able to help people. And even though it's often said that oncologists go through, that it's a very difficult job to do, and it is very difficult, and you mentioned young people with cancer, but on the other hand, there's enormous satisfaction and rewards from being able to help people, no matter whether they're young or old. And it's said that the more you give, the more you get. And so giving of yourself in order to help people is a wonderful privilege, really, in the sense of being able to participate in that relationship with people, and still, but at the same time, you can't, the patients that you treat can't be family. They are a family in a way, but you have to somehow separate yourself from how close that interaction might become.
Yeah.
And that's not always easy. In fact, it's mostly difficult and mostly doesn't work. But you do what you can.
Yeah. And a lot of people who have achieved what you've achieved and hold the roles that you have now would be justified in not doing clinics anymore, but you do them. To the best of my knowledge, you're still seeing patients and you're still treating patients today, and that obviously speaks volumes as to the passion for that patients, because it's I guess it's what makes your job real.
Yeah, well, look, in the end, I go back to where we started, which is I went into medicine because you want to sort of, perhaps it's a bit naive, but you do, but in a way, but it's about helping people and trying to give people the best opportunities in life. And so to give up, I'm at an age where you think about what's the future now, and to think about giving up patients is the hardest thing of all, because it's why I started this journey in the first place.
Yeah.
So giving up patient care feels like it's going to be an enormous step into a void that I don't know where I'm going to land.
Yeah, fair enough.
But so for them, I continue it, and I hope I can continue to do so.
Yeah. I'd like to talk a little bit about clinical trials, but before I do, could you, given that most of our viewers will be patients and they're aware of it, could you give a 1 or 2 sentence minute overview of what a clinical trial is and why it's important?
A clinical trial for me is just part of the research effort that goes on in all of medicine and outside of medicine as well, but of course it goes on in medicine. And all the progress we've made in medicine relies on research that allows us to understand what do we do now and how do we move forward. But there's a sort of myth around clinical trials. For me, research in medicine is about how do we do it better. As you know, in some areas we do very well, we cure people with certain conditions, but in oncology there's a lot still to be done. And research is a tool, research is a thinking that says how do we do it better. That's all it is. And the tools you've got, so you say, okay, you want to do it better, fine, that's a good thing. How are you going to do that? You use a tool. And the tool is, one of the tools in any case, is a clinical trial. Mm-hmm. So a clinical trial is a mechanism that allows you to actually ask the question and have an answer. How do you do it better? And sometimes you do a trial and the answer is it didn't help. Mm. And sometimes you do a trial and you make enormous progress.
Yeah.
And that, of course, is what we're striving for.
Yeah, and it leads to that question of some of the things that have been occupying my mind are the complexities of cancer, and I think the easiest way for me to ask this question is that clinical trials can be at best three-dimensional, if you like, in that they sit in this real world, but sometimes it feels, when I look at what little I understand of the science, that the problem we're trying to solve is a 10-dimensional problem with cancer, and I wonder if there's an opportunity at some point to be braver or bolder with the design of trials. In other words, we seem to go down a very incremental path, and is there an opportunity that we could explore to be more ambitious?
It's a really good question, and I definitely think there's room to be more ambitious, but in a way, I haven't really thought about this, but in quite this way before, but we are almost a victim of the scientific methodology. So if you, perhaps the example is, we've got a mixture of drugs and we want to see whether or not people are better off at the end. The scientific methodology is not that. The scientific methodology is what is the contribution of each of those drugs in the mixture. Diet's a common, diet, everyone wants diet to cure cancer or prevent cancer. But diet is, whatever you had for lunch or for breakfast. It's a very complex, it's different types of grains, it's different proteins, they're all different. And yet the scientific method is, well, if we're going to test vegetables, it's got to be a certain vegetable made in a certain way. I'm being a bit silly in the example, but what I'm getting at is the scientific method is about narrowing everything down so that when you say a certain thing causes a benefit, that you know what that thing is. So if it's a drug that causes a benefit, it's exactly that drug. It's not the thing it's mixed in, it's not the glass ampoule it came in, it's not the way it was carried, it's just the drug in the bottle. And yet that in its own account suddenly means, but hang on, if we took 5 drugs and put them all together and we got this fantastic outcome, wouldn't that be good? And our scientific method would say, no, we don't, but yes, that's good. But actually I want to know what each one does, because then otherwise we're going to pay for it all, but one of them may not work. Right? Yeah. So, but in the general, coming back to the general tenor of your question, I do agree that we need to be more ambitious, and I think, no one isn't ambitious in this area. Everybody wants the cure, everybody wants dramatic benefit for patients and for the community overall. But achieving remains a challenge, and the problem with being very ambitious is that you throw out drugs that are half as good.
Yeah.
So half as good a cure, if cure is the ultimate, and half as good is half a cure, whatever that really means, I don't really know. But if you throw it out because you didn't get a cure, is that a good thing?
Yeah, then you've got nothing.
You've got nothing. Yeah. Exactly right. You've got nothing. So what do you do then? So is it better to say, well, let's just go up little increments at a time, one step at a time? That's been said before.
Yeah.
One step at a time, we'll get to the top.
Yep.
We'll get to the other side. Or go for the top in one jump, but if you don't make it, you're back at the bottom.
Yeah. Snakes and ladders. Yeah, fair enough. But part of that, of course, means when we do come across the opportunity for combination therapies, where we've got multiple drugs that we think will work together, we also have a challenge within our health systems to get them both approved and reimbursed. And and you and I have co-chaired the Cancer Drugs Alliance, the National Oncology Alliance, and it's always seemed to me that Australia lives in this fantasy that we have a universal healthcare system and that everything we want is on the PBS. And not many clinicians have been prepared to say that's not the case, and you're one of them, which is heartening. And how do you see the system as it is today, I guess is the question.
It depends on, I guess it depends on the sort of mood I'm in some ways. So on the one hand, the PBS, remember the PBS started in the 50s and started from an environment where only people paid for everything. And most people didn't get what was needed, even simple medication. So the PBS has been a fantastic public health program that has provided many effective drugs to a majority of the population. So that's a very, I think we look back on that and be very proud of what we've achieved as a community. On the other hand, the PBS is limited in its structure, in the way, or the processes that underpin whether a drug is available or not, is complex and somewhat bureaucratized, and unfortunately doesn't always provide the most recent drugs to the people who need them quickly and urgently. So I first got involved in the debate around access to drugs when I realized that if a wealthy person came in, they could get whatever drug they wanted, whenever they wanted, however they wanted. And the next person who couldn't afford that, and sometimes we're talking about very large sums of money, could not get those drugs. And so for me, that was an inherently inequitable situation. I don't at all think it's wrong that wealthy people get access to those drugs if they are able to afford it, great. But why can't the rest of the community have access to the same drugs if they work? And that should be a decision, as you and I have discussed, between the patient and the doctor. And the trouble is they don't. And often when people say to me, friends or family have involved with doctors and they will ask me about what should they ask their own doctor. And I often say things like, if it was you, what would you have? But the other one is, if money was no object, how would I be treated? Because we've got to get rid of that. I think if money is if that's the problem, then let's solve the problem later on. But let's at least decide what's the best treatment. You don't get a second chance at life. Nobody does. And if you've got a serious life-threatening illness, then I think you're entitled to receive the best. And I think our society expects that, and I don't think they always get it.
Yeah. No, I 100% agree. And which brings me to the question of when we look at, and you made a comment once in my presence when we were talking about non-PBS medicines. And there's obviously a gap. Today a drug will be reimbursed, will be registered with the Food and Drug Administration in the United States, and that means it's gone through quite rigorous testing for efficacy and safety. But that will take an extended period of time before if it's ever available on the PBS. And clearly there's evidence. But you said once in my presence that you can be sitting there talking to a patient and thinking about possible treatments and possible treatment scenarios, and after 40 years, sometimes you just know as a clinician. And I wonder in that context how you reconcile that with the fact that there are a bunch of economists and public servants, of good people all making decisions about what's available in fairness, and how do we reconcile that system with your 40 years, if you know what I mean? Yeah,
look, I have thought about this a lot, Richard, and our discussions together reflect that. I was in the end, I've come to the view that as doctors, we're concerned with the person sitting in front of us, trying to deliver the best care, trying to give them the best chance at life, the best chance of cure, and reducing suffering. When you sit in a committee room and you're debating health economics and so on, I think that I agree with you, these are good people, smart people, but I think the agenda's different. I don't think they're thinking about the patient sitting in front of them and what they're going to tell them. I think I don't know this, but I think what they're considering is the broader societal implications of funding a program that in the end might cost X million down the track for the communities of the future. However, maybe it's part of medical training, but you can't get away from the person sitting in front of you. And to say, Richard, I can't give you this drug because the society can't afford it, in 20 years' time we won't be able to afford this drug, and you've got to sit there and say, fair enough, that's not the way it works. No. And so my own view is that we've got to strive to do the best we can for the patients that are in front of us, and we've got to try and improve life and opportunities for patients who are going to be in front of us, if not me personally, of course, or colleagues. So I agree that there needs to be a system that considers cost and so forth. I'm not saying we can do this in an environment where you don't consider that at all. But I think there is enormous room for improvement. And I think, and we still struggle, as you know so well and much better than I, with rare conditions, rare cancer, but rare conditions as well. We struggle when for relatively small sums of money, and yet we somehow get stuck around them. When I think really we owe it we have a responsibility to the people in front of us to do better.
Yeah, I totally agree. So if you were king for a day, and you had an opportunity to come in and provide some solutions, which is the most attractive? You know, the Cancer Drugs Fund, the real world evidence, all of these things that we've talked about. How do we get drugs to patients quickly and acknowledge the expertise of clinicians in the process?
They probably would never make me king for a day, that's for sure. But and it's not I guess it's easier to complain than it is to come up with solutions. But there are countries around the world where the issues around cost are important, but they're not paramount. And the sense we get here is that cost is as important, if not more important. The cost to the community is as important as actual provision of the drug in the first place. So my view, the principles, the way I'd approach this would be that the first thing and patients with cancer, the other thing we need to recognise, it's often said cancer is not the only serious life-threatening condition. That's true. But the complexity with cancer that I guess, at least in my bias, changes the paradigm somewhat, is that you don't get a second chance. There isn't, well, I've got coronary artery disease. I'll have coronary artery disease today, and if I'm alive, I'll have it in a year's time. Maybe a bit more severe, but I've got coronary artery disease, and a new drug that comes along that will lower my risk of major events, that's really important, but I can wait. At least that's my sort of simplistic thinking of it. But if you've got a diagnosis of a serious cancer, you may or may not be alive in a year's time to there's no waiting opportunity. So from my perspective, the principle needs to be initially access to the best available treatments, and that's based on safety and efficacy. It's not based on cost. And there is a cost discussion, but it occurs after the fact. And there are countries, for example, which will provide the drug at the price, whatever the market price is, and then say, well, you've got a year or two to work out the costs. And we'll do that afterwards. So we've got to work it out. But in the meantime, people access the drug. And there are various ways you can do that in a controlled manner. You could do it through a clinical trial network. You could do it through a registry process. You could do it through some other process. But at the end of the day, what's critical is that access is provided whilst the health economist and the government and the industry sponsor and patients and clinicians work out what's a fair value for that benefit. But let's not argue about it while patients are dying.
No.
That's what's happening.
Yeah, I totally agree. You talked about registries, and I know they're a passion of yours. And for those watching, a registry is a log of data, patient by patient data, that gives us a capacity to analyse the impact of medicines in the real world. And does Australia have problems with the way that it works with data, the level of silos in hospitals and states? And obviously I think it does, but you're an expert. So.
Well, look, I think it's often said we've got problems with data, and I think the issues that we've got not so much are, there's a lot of data in the system already. There's a lot of data being collected. What we have is a problem in bringing data sources together in a health environment to improve outcomes of patients. And that's clearly what medicine is all about. So a registry, I'm interested in quality registries. So what they do is they measure quality of care. And our current assistant treasurer has, on the public record with a very simple statement: if you can't measure it, you can't manage it. And that's what a registry is about. If we're providing $160 billion annually for healthcare and we don't measure what we're achieving, how can we manage the system? And that cost is only going to go up. So from my perspective, a quality registry is a way of engaging clinicians in understanding the quality of care they provide, seeing why there's variation and what the impact of that is, and driving improvement. It's all about improvement, it's all about doing better. It's not to say we're doing badly, it's about doing better. And that's what a registry does. And a registry just uses existing data sources to do that. So there are data in electronic medical records, there are data the Commonwealth holds, there are data that the state government holds. And everybody, as you say, just holds them in a silo. Yeah. Rarely do they bring them together. There are new attempts to do that. I think the Commonwealth has a data transparency legislation that's going to help. But what we've got to do is create a culture, and again, I think the community's got the best chance of driving this. You guys stop fighting over who owns the data. It's our data, it's about us, and we want it to be used to help us. Go and do the job, guys.
Yeah, I think we can run a campaign based on that last 30 seconds. I think it would be highly compelling. So I think that we're getting towards the end of this conversation. But when we wrote Vision 2030, which is the driver, the catalyst, if you like, for the Australian Cancer Plan that's currently being developed, we set as a goal 90% 5-year survival, or 5-year survival of 90% for all cancers and all patients by 2030. And I wonder if you think we've got a chance of getting, currently I understand it's nearly 70% survival, but I wonder if you think there is an opportunity to push that harder over the next 8 to 10 years and what we might do.
I think, I'm not sure if we'll get to 90% or not, but as you say, it's close to 70% people newly diagnosed with cancer are currently cured. And cure is a very special word here. That means that there's a cancer that was present that's gone and doesn't come back. So from my perspective, the low-hanging fruit here, so to speak, is particularly going to be in the early detection of cancer. And I think, so currently we have 3 screening programs in Australia. We have a bowel cancer screening program, a breast cancer screening program, and a cervical cancer screening program. About 50% of the community are involved or being accessing, if you like, the bowel cancer screening program, and a similar number for the breast cancer screening program. If we can get those numbers up to 70, 80, 90% of screening, people being screened, we will make an enormous difference. So I think I see real opportunities in the screening space. I think smoking prevalence, which is an important cause of cancer, has fallen a lot in Australia. We've had very effective public health campaigns, and I'm not sure whether we're going to get much lower, but so I'm not sure there's going to be enormous gains there. I think in terms of the treatment opportunities, apart from earlier diagnosis, so screening is basically about early diagnosis.
Yep.
It's picking up the cancers that will kill people, but picking them up when they're small enough or localized enough to be cured. I think when it comes to the treatment space, look, the way I just went to the American Society of Clinical Oncology meeting, as you did, Richard, in Chicago, and I was sitting in one of the lecture halls listening to some talks, and I felt like I was about to be washed over by this incredible wave of new drugs, new opportunities, new devices, new approaches, new thinking. There are enormous things coming our way. And I have no doubt that a number of them, not all of them of course, and maybe not even the majority, but a number of them will have very significant impacts on patients with even more advanced diseases where screening isn't applicable or appropriate or proven to have value. So I feel like 2030, whether we hit that target or not, it's a fantastic aspirational target. We've got to have an ambitious target. We've got to be ambitious in the way we approach treatment opportunities, and we've got to find ways of working together better. I mean, I think the part of the issue is combinations of drugs, and as you know, Richard, when combinations are held by different companies, there is increasing companies working together to say, well, your drug and my drug, let's mix them and see what happens. Yep. But it could be done a lot more, I think.
Yeah, I think that's a really interesting question and a great point to leave it on. So thank you. Thanks, John. It's been a pleasure.
Thank you, Richard. Likewise, it's been a pleasure.
Thank you for joining us for this episode of the RCA Thought Leader series. To receive each new episode in your inbox, you can subscribe to the series at rarecancers.org.au/Thought Leader series. We look forward to sharing the next candid conversation on cancer soon.